good afternoon, or evening, and welcome. Kensington Senior Living has 7 unique communities, 4 located in Virginia, Maryland, and New York, and 3 sister communities located in California. Kensington is truly privileged to support care partners and professionals from coast to coast. Kensington focuses on relationship-based care, care built on the foundation to love and care for your family as we do our own. That promise is what initially drew me to become a member of the Kensington family, as my father lived there for almost 7 years. It is programs such as the one you're attending now that are so important for those of us walking through a caregiver journey. To hear from expert professionals on keeping us current with the latest advances in care, management, and treatment of conditions that affect seniors and their families. Today's webinar focuses on the difference between palliative care and hospice care. Our panel of experts will present a multidisciplinary approach to palliative care and hospice, learning from these mentors in geriatrics and receive their top tips and coping strategies. They will lay the groundwork on navigating both approaches to palliative care and hospice and share their support services. Please join me in welcoming Dr. Grant Smith. Grant, can you please join me and share a few words about yourself and introduce today's program?
Yes, thank you so much, Susan, and thank you for inviting us to this wonderful community. As Susan mentioned, my name is Grant Smith, and I'm a palliative care doctor at Stanford. And I work both on the inpatient setting, so in the hospital, seeing people who are hospitalized, as well as in our outpatient clinic here in Palo Alto. And Susan asked me to start by sharing a bit about why I went into the field of palliative care. And we'll be talking later more about what that field entails. But one of my formative experiences early on was I actually worked with an obstetrics and gynecology doctor, and I worked with him in Tanzania. And he was there with his family working to work on improving maternal mortality. Ultimately, I obviously did not go into obstetrics and gynecology, but one of the lessons that he taught me as sort of a person early before I actually started medical school was I was trying to get advice from him about like, how do you sort of find your career and your path? And one of the pieces of advice that he gave me was to find a career in medicine where you're a little bit angry or a little bit pissed off, to be honest, about how that care is being delivered. And as I went through medical school, that area for me ended up being a bit frustrated with how I saw people who were living with serious illness be treated. I saw cases where individuals were kind of going through the medical machine, going through the algorithms and sort of the automatic processes that happen in medicine. And I saw the human, the person that really was supposed to be the center of our care sometimes get left behind in that process and in those automatic ways of treating people. And when I learned about and saw palliative care in medical school, I saw that it was really those doctors that took the time to get to know the individuals they were caring for, learn about what was most important to them, and then advocate to make sure that their care matched up with what was most important. So it was really that idea of like, where do I feel a real passion to make a difference, where I feel like there's some injustice or something left to be done? That's what really brought me to palliative care. So with that background, let's talk a bit more about the rest of today's program. First, I'm going to be sharing some information about palliative care and hospice, again, just really as groundwork for our discussion. Next, I'll introduce our other panelists, and they will share a bit more about themselves and what brought them to this work. And then our panelists will share a bit more about their personal and professional experiences working with people living with dementia. We'll also share some of our top tips for people and families living with dementia. And then finally, we should have plenty of time for questions and further discussion. So let's start by covering some of the basics about palliative care. And when I think about palliative care, I think it's sometimes most helpful to talk about how palliative care is different from other specialties or other sort of doctor's offices or other approaches to care. And I often think of palliative care as really providing holistic or whole person care. We often like to say in palliative care that we see the person first, and we think of it as the individual living with an illness and that person's family, friends, or those close to the individual as really at the center of our care. Sometimes we even do this in the language we use. So I think about the individuals I'm interacting with as a person living with dementia rather than a dementia patient. And you can kind of see the difference there is that a person living with dementia, we put that person first. And a dementia patient is more of a label. And so it's really that type of mindset that we put in the center and the focus of our care. Palliative care, I believe, is unique in that we recognize that difficult illnesses like dementia, we know they can affect the body and cause physical symptoms, whether that's things like pain or maybe constipation. And we know that there are psychological, emotional, spiritual, and practical concerns that can come up for both the individual living with an illness and their loved ones and caregivers. So we kind of understand that multiple domains of life can be affected when someone's living with a tough or difficult illness. To provide that holistic care that we talked about, we work as an interdisciplinary team, and we'll get to hear more about that from our other panelists. As an example of that, I'm a doctor, so as a doctor on the team, I might work on helping to prescribe medicines to help treat some of those physical symptoms. I may help an individual and their family think through what decisions may come up in the future. What will the course of this illness look like in the future? I also can be pretty helpful in coordinating with other doctors. I spend a lot of my time sending emails and messages and making phone calls to other doctors about what's the overall care plan. Let me share with you what I've learned about this patient so that we can help make sure our care matches up with what's important to them. I know that I need help with some of the areas of care that I'm not as expert in, and so I rely on my team to help me. For example, our social workers often help providing emotional support or support to caregivers, or provide assistance with practical things like maybe where can you go to find extra help for your loved one if that's needed. Our chaplains or our spiritual care providers help with exploring areas of something we sometimes call existential distress. Those might be things like wondering, gosh, why is this happening to me? Or what's God's plan in all of this for me? Our chaplains also offer prayers, blessings, and help individuals access their inner strength or their spiritual strength. When I think about what is the goal of palliative care, our goal is really to be an extra layer of support in addition to the other doctors and other medical teams, and we focus on improving quality of life. In something like dementia care, we may help with symptoms like I mentioned. Sometimes that can be behavioral changes, pain, constipation, and we really want to help support caregivers because we know how crucial and critical caregiving is and how challenging it can be when working with someone with dementia. We also help people, as I mentioned before, help think about their future care and what type of care an individual might want if they were to get more sick in the future. Sometimes that involves doing things like helping complete an advanced directive or a living will, if you've heard of those. A lot of people wonder, well, where is palliative care available? And it's often provided in hospitals, in clinics. So just like going to see an outpatient clinic doctor or a specialist like a neurologist, you can see a palliative care specialist through a clinic. We provide a lot of care through telehealth, and in some cases through home-based care, having a team visit the individual in their home. So now that I've spoken a bit about palliative care, let's go on to talk a little bit more about hospice. When I do that, I often sort of think about the relationship between palliative care and hospice. And I think of palliative care as sort of the umbrella concept, a bit of a larger concept. And hospice is a part of palliative care or a type of palliative care. And hospice is a type of palliative care that really focuses on caring for individuals who are in that final phase or the last phase of their life. And often that's a time when the time that someone may have left to live is on the order of months. Hospice is similar to palliative care in that the focus is on improving someone's quality of life. making life as good as it can be, regardless of the underlying illness. I would say where hospice and palliative care are a bit different is that hospice is really when that comfort and quality of life is the number one priority. And it's sort of so much a priority that often hospice is a good fit when people are feeling more comfortable, perhaps foregoing treating the underlying illness. I often think that a hospice will think they want to do anything and everything that can make each individual day be as good as it can be. So whether it's a medication, an intervention, even taking a blood pressure, a hospice will sort of help ask, does this thing help today be better? And if it is, they'll want to do that. But if it's an intervention or monitoring or a medication that is aimed at treating the underlying illness or doesn't really contribute to making that day better, they would recommend that maybe that's not something that's worth doing when the goals are really to make each day as good as it can be. I think a good example of this is sometimes thinking about giving chemotherapy for someone living with cancer. Chemotherapy is typically not something that's part of a hospice care plan because it doesn't really help someone feel better that day. It's really meant to treat the underlying illness and for sort of longer term benefits. I'll add here that hospice provides care in the place for an individual in the place where they're likely to be the most comfortable and where their other care needs can be met. Most of hospice is provided in a home and often in the individual or family member's home, but it also can be provided in a nursing facility or nursing home. Hospice includes care from a doctor, nurses, social workers, and chaplains, much like palliative care. And I think some of the really great benefits of hospice is that it provides 24-hour phone support from a nurse and can even send a nurse to the home or wherever the individual is if new issues come up. Hospice also helps provide medications for comfort and medical equipment if needed. So let me pause there. I've kind of downloaded and dumped a lot of information about palliative care and hospice to sort of just get us started. But I'd like to go ahead and introduce and welcome our other panelists, and they'll tell you more about their role and how they got into this work. But I just wanted to introduce them with sort of a warm introduction for how I know and how I work with these individuals. I'll start by introducing Naomi, and she's a chaplain at UCSF. And I did my fellowship, my palliative care training at UCSF. And I can tell you that Naomi is the person that I learned the most from in my fellowship. She is the epitome of a palliative care chaplain and is really known nationally as this is what it means to be a palliative care chaplain. So we're very lucky to have her. Next, Jeong Min is one of our social workers in our clinic at Stanford. So we work closely together in our outpatient clinic in Palo Alto. And I've seen her just be an amazing support for our patients. She often is providing steady guidance through very tumultuous times for individuals. And I just cannot have more gratitude to the support she provides my patients and honestly to our team too. And then next, Carla, who is really an expert geriatrician, palliative care doctor, and hospice provider. She has been a mentor to me for almost a decade. Carla, I don't know if you realize I was doing the math and I can't believe that that's the case. But I will tell you that Carla is one of the doctors that I hold in my mind as someone who I most want to emulate. She is brilliant and she is a fierce advocate for her patients. So I'm very touched that this, everyone here came and much at my request. So I very much thank you for being here. And let me turn over to Naomi to introduce herself and tell you more about her role and how she got into this work.
Hello, everyone, and thank you so much, Grant. It's really a delight to be here. As Grant said, I am a clinical healthcare chaplain in palliative care. I work at University of California, San Francisco in the palliative care service. And I'm also in charge of really supporting physicians, nurses, chaplains, social workers in well-being and sustainability so that we can continue to do the work we love for decades and decades and stay healthy doing it. I came into this role, like many of us, from a personal experience about 19 years ago, my father was diagnosed with pancreatic cancer, and he was this big personality, A-type person who rode horses and flew airplanes and hiked and had fierce opinions about everything. And when he became sick, it really took his whole identity away, and he really didn't know how to keep going. And I had the honor of being with him and accompanying him, and even syncopating my breath to his breath, and holding him and talking to him while he was at the end of his life. And something just occurred to me inside that I never felt so useful in my life. And when he was at the end of his life at the hospital, they asked us if we'd like to see a chaplain, and we're like, no, we're not religious, and we don't even know what a chaplain is, and we don't need to be polite to anyone, and we don't need another person. And they said, no, this person's really special, you know, I think she could be helpful. So we said, okay. And so this amazing chaplain came in, and she brought such love and such space and such gentleness to a really hard time for all of us, that something just ignited inside of me. And I called her up 6 months later and I said, what's this chaplain thing? And I never realized it, but my whole life I wanted to be intimate with the human condition, and being a chaplain allows me to accompany it day to day, just in a beautiful way. And so I've just continued to learn and grow and just be so gifted by sitting deeply at the bedside of people. Thanks so much. I want to turn it over to Jeong Min.
Thank you, Naomi. Good afternoon and evening. Thank you so much for having me. My name is Jeong Min, and like Dr. Smith mentioned, I work at Stanford outpatient palliative care as a social worker, and I provide emotional support and counseling, as well as addressing practical needs for our patients and families. How I got into this field, while in graduate school in New York, I took a course on death and dying, and we watched a video of a social worker doing hospice work. I really didn't think much of it, as I was interested in working with children at that time. After graduation, I returned to California, my home state, and had a really difficult time finding a job working with children, and somehow ended up at a hospice agency. During orientation, I met staff, including a gentleman who I immediately recognized. He was the social worker in that video I had watched in school, Jim Brigham. So I thought this must be a sign that I shouldn't ignore, at the very least, to be open to this line of work. And hospice palliative care is where I've spent the majority of my career now, and where I hope to stay. Thank you.
Thank you so much, Jeong Min, and we'll turn over to Carla.
Hi, everyone. So as Grant said, my name is Carla Perissinotto. I'm a geriatrician and palliative medicine physician. I entered geriatrics actually first because I realized as I was going through medical school that who I loved talking to were older adults. And I thought that we weren't doing a great job taking care of older adults. In my training in geriatrics, a lot of the care that I was providing was palliative, meaning that we were really focused on someone's quality of life, prioritizing the care. And in many ways, the palliative piece and the geriatric piece is really what I envisioned when I was going to be a physician. It was someone who was holistic, who thought about the whole person, thought about the person in the context of their family, their community, their beliefs. And in my work in geriatrics, saw a lot of people with serious illness, both acute and chronic, and often mistreated in the healthcare system, overtreated, not recognizing someone's prognosis, and sometimes undertreated because of ageism. And that really brought me to meld the two fields together, and most recently working in hospice, because as I was referring my own patients with hospice, I thought, wow, hospice was traditionally built for people with cancer. And now we have people living with chronic conditions like dementia. And how do we think about that? And how are the needs different? That's it.
Thank you, Carla, Naomi, and Jeong Min. Really appreciate you all sharing some of your stories. Next, I'm hoping that we can also go around and have more of a discussion with each other too. Would love to hear people's experiences, either professionally or personally, if you would like to share, if you have experiences with dementia. And then also, if you're willing to share maybe some top tips that you might give to individuals, families who are living with this condition. I'm wondering, Naomi, would you be willing maybe just to get us started? And again, for all the rest of us too, let's feel free to jump in and comment as we go.
Sure, thanks, Grant. I remember years ago when I was training to be a chaplain, I used to go into rooms of people who were facing some kind of dementia or cognitive challenges. And some of them were not interactive. Some of them were sitting with their hands folded in their laps for hours. Others were in their bed under their blankets. And I just remember feeling there's people here. There's a human being. There's a whole person with a history, with children, with life, with memories. There's somebody's daughter. There's somebody's son. And I really just became really interested in how to continue to engage and support and be there and deeply accompany people who were facing Alzheimer's, dementia, and other kinds of dementia. And I remember one patient, and a woman that I'll never forget, Evelyn. And Evelyn was facing Alzheimer's. And the first time I met her husband, Tom, outside her room. And Tom was very upset. He kept saying, everyone keeps telling me Evelyn doesn't remember anything, that she doesn't remember. And he said, I remember her. I remember her, and I will never forget her. And he told me all about her. And in the minute that Evelyn first was a woman with folded hands in a chair, the minute he told me the story, she became a full human being with beautiful life, full of colors and full of beautiful experiences. And he told me that she used to sing in the chorus, and that she used to go to nursing facilities and sing for people. And so we went into the room, and as many people know, the short-term memory may go, but the long-term memory is still there. And many parts of the brain that can sing, that can smell, that can see colors continues. So we sat there, and I'll never forget it. We started really slowly. This little light of mine, I'm gonna let it shine. And all of a sudden her eyes opened a little bit. This little light of mine, I'm gonna let it shine. And then her mouth opened and she started to sing, and this beautiful voice came out, and she joined with us, and we were rocking that room, Tom, me, and Evelyn. And I'll never forget how she lit up, and this person, and then others came in and listened to her sing, and we got to see this whole person in front of us. And I'll never forget that. And that story, and Evelyn and Tom and people like them, they're my teachers, and they continue to be my teachers. I wanted to share a few things that my teachers have taught me. They have taught me that our feelings don't get Alzheimer's. Our feelings do not forget. And when words fail our loved ones who are facing this, when the short-term memory might fade, we can gently shift to focus on what is here now, not the words, not remembering, not the facts, but deeply accompanying people through the feelings. They still are going through amazing feelings that need to be transported and processed, and allowing people to express emotions through what is still familiar to them: love, peace, hope, joy, frustration, sorrow. It's such a beautiful way that not only can they process their feelings and experience, but we can connect with them and also continue to be in relationship with them. Another thing my teachers have taught me is that people who are facing Alzheimer's and dementia, other kinds of cognitive challenges at any point in their life, and especially at the end of their life, they still are going through the same major life transitions that all of us go through. And that they still do need support with life review. They still need to tell their stories, maybe not with words, but bringing them a picture Maybe they can't make their favorite family lasagna recipe, but they sure can smell it if you make it for them, and they can sure remember that. Maybe they can't garden anymore, but they can look at gorgeous blossoms in spring and feel the colors in their DNA. And so maybe they can't remember all the facts of their anniversary of that wedding day, but they can see the wedding dress and they can feel the satin and the lace and they can feel the corners of the veil. And so I really learned from them that we need to help people no matter where they are in their life and whatever they're dealing with. We really need to help them through their senses, through their experience, to continue to process and review their life and remember moments that were important and make meaning of this. Just because they can't knit the sentences together or they have trouble, they are still processing, and there are so many mysterious processes that are going on at this part of their life. The last thing they taught me was for the caregivers, for those of us who adore and love and cherish and remember people who are facing these kind of conditions, is to be easy with yourself. You're going to have times when you're frustrated. You're going to have times you feel guilt that you're not doing the right thing, or did you do the right thing? You're going to have times of inspiration and joy and memory and connection and grief and sorrow. And to really, there is no perfect with this, that we all are walking each other home and we're doing the best we can, and simply being with someone, not fixing, not changing, but deeply accompanying them is more, sometimes more than enough, more than words can say. Thank you.
Maybe we can just open it up to Jeong Min, Carla, if other comments. I'll, if it's okay, I might just start to say, Naomi, I feel like this is why we operate as an interdisciplinary team. I think sometimes, and Carla, I don't know if you feel this way too, but we know that our medications are limited in this space. We don't have perfect medications, and yet there's still so much care and healing in the broadest sense of that term that's available. And I just hearing your words, Naomi, is helping me remember all of that it's easy to forget in our medical model. We're moving through a clinic day, and I just think that highlights this is why we need the whole team to provide the whole care.
I'm so grateful, Naomi, to what you said. And I think just that remembering the person, and Grant, you started us out by talking about saying people living with dementia, because it's not the common words that are used. And I think we often, I think because we're ageist, and I think we're scared of this happening to ourselves, and we treat people with dementia like these foreign, scary people, rather than what Naomi just said, is that there's a person there. And it's one of my favorite things about what I do, is what I find out with these amazing careers that people have had, and amazing life stories and family stories. And we don't get that. And so how can we channel that, as Naomi said, is huge. I think there's some probably some sobering things that I will say that are my tips. And this comes from my role. I think, Grant, thank you for describing me as you did, because I hope when I teach, I hope if anything, I teach us all to be advocates for ourselves, for our families, and our patients. And I think there's, with dementia, it is a huge place where we have to advocate, because there's so much that we don't know. And there's actually a lot of harm that we do in medicine, not on purpose, but because we don't stop to talk to that person. We don't stop and find out, like I just did with my team, that one of my patients with severe behavioral troubles has a history of sexual trauma, and no wonder she is having trouble with ADLs. We don't stop and ask those questions. And if we don't advocate, ask family members and say, hey, my mom has this history, then I can't do my job well as a physician, nor can my home health aide, nor can my nurse. So it's advocacy, which is so huge. It also means that, sometimes doctors are pill pushers. And while there's many medications that can be helpful, it's a duty for us as clinicians and as family members and as other IDG team members to say, hey, this medicine it may help this symptom, but it may cause something else. And for Naomi to say, hey, Dr. Grant, after you gave this medicine, she doesn't look so good. So we can backtrack, right? And then the last thing I will say is that unfortunately for many, dementia is a terminal diagnosis. It does not mean that once you have that diagnosis, you're dying tomorrow. You can still have great quality of life, but we forget. And that's important because the treatments we may offer to people with someone who has dementia are going to be more complicated. And so we have to be really, really thoughtful about how we do this. So that's my 5 cents in 2 cent time period.
Oh, thank you, Carla. Just continue to open up if other folks have thoughts or reflections on Carla's comments or anything else.
I'm just kind of trying to process everything. I just feel like I'm just really feel just the work, and the personal experiences that influence so much of what we do. And for me, professionally, I've worked with many families with dementia in both hospice and palliative care. And more recently it became personal as my mother was diagnosed with Alzheimer's a few years ago. And after she had returned to her home country, we brought her back to the States 2 years ago, and we now take care of her in our home. So I really come with a much deeper level of appreciation for what families live with, all the struggles, sadness, loss, but also many, many moments of joy, immense gratitude, and even laughter. And, I thought hard about what my top tips would be as both, professionally and personally. And I do try to practice this as well. But I think my first tip would be, create a trusted community. This illness can be very, very isolating, as Dr. Has mentioned. In addition to family and friends, consider joining support groups, attend workshops, or even therapy for yourself. And I really think that creating a community means accepting help. And I think people really just have a hard time admitting they need help, and for a variety of reasons. But when we do, we really lessen the isolation that we feel and then gain the confidence we need to sustain ourselves. The other tip I try to practice and certainly talk to my patients about a lot as well is avoid the bait. And this is more for those in the moment encounters where caregivers are often faced with the behaviors that are so common in dementia, like agitation, paranoia, repeated questioning, all of which I want to stress stem from the illness and not the person, right? Once we avoid the bait, meaning not getting caught up with trying to reason or convince otherwise, we then can move into a graceful cue, which could be a distraction, playing music, acknowledging the emotions. You must have been so worried, or offering an activity that they really enjoy. Let's go have some tea. Let me make you something that something for you right now.
Thank you so much, Jeong Min. I may piggyback a little bit off of what you said, because that was sort of touches on some of the things I was thinking as also kind of top tips. And just as Jeong Min was alluding to, caregiving, I think, is so much that I see in my clinical practice, that caregivers is such a challenge. And I think my sort of top tip around this is sort of related to your idea of like having a trusted community, and that it sort of takes a village to provide this care. And I often find myself reminding caregivers that caring for someone with dementia is not a sprint, and that you will burn out if you don't think of it as a marathon. Even with it being a terminal illness, the pace of that can be very variable and can be long. And I hear a lot of caregivers express feelings of guilt for doing even the most basic things, like going out to get groceries or doing any single thing that's like rejuvenating to them. And I just try to counsel people, like, that is caring for your loved one. Like, if you break down, we're in trouble. Everyone's going to be in trouble. So taking that time to do whatever it is that fills your cup is so important and not at all like a selfish thing. That is like how you're also loving the person you're caring for. So I really appreciate your comments and feel so similarly that it's important for that self-care piece. Other questions or comments from what's been said so far? I know that we have some questions that were asked before the session. There may be some coming up, and I would just encourage anyone who's on, feel free to populate the Q&A with your questions. We really want to make this time as valuable to you as possible. You've got a great panel of experts here with us, so we're happy to answer your questions.
I am in awe, and I feel so privileged to even be on the screen sharing it with the four of you. And I'll try not to cry, but that was amazing. Before I forget, everyone today that registered will receive a copy to share with friends and family. And boy, do I recommend that you share this with friends and family. We'll also include links to connect you with these amazing people that, I mean, filled with passion, emotion, support, and love. It just doesn't get better. And I love, first of all, I'm going to tattoo this somewhere because my father died of Alzheimer's, but feelings don't get Alzheimer's. I mean, it's so true, but it's so hard to tap into that, and you just have to be. And I love what you said, Naomi. I think everybody said it, but you just have to be. And Jeong Min, I'm so sorry for your situation with your mother. There's just nothing worse. It's the longest goodbye ever. And my dad was on hospice, and Naomi, I must share with you, they said, would you like to see Chaplain Charlie? And I said, no. I said, we're good. My brother was in town. He didn't live close, and I had my mother, and I was texting with Chaplain Charlie for the rest of my father's life. It was the most incredible thing. He gave so much support to my team, my brother, my mother, and I, and then my husband and my kids and my niece and nephew. He just brought us all together in such a good place. So I recommend to everyone that you take Naomi on her offer. And Grant Smith, to bring this team together, thank you. I can't thank you enough. We actually had a question come in from Helen, and I'm going to start with that. And I think you're all going to feel passionate about this question because actually I do. And that is, how do we change the stigma and confusion about palliative care? I would like to see it recommended at date of diagnosis with dementia, so the quality of life is put first and support services available. I'm going to let Grant start because you're nodding the hardest.
Well, I agree that I think one of the big missions in our field is to recognize and know that we want to be moving upstream. And there's been a lot of research, particularly in cancer patients, but I believe this is true to other diagnoses, that we are most effective when we get involved early on. We can sort of do our best work when we start from the start. I think we have a lot of work to do. I think there are two parts of kind of that solving this problem. And one is doing what we're doing today, getting out in the public, reaching community members to let people know about what palliative care is, how it can be helpful, and really it's kind of that grassroots movement to get these services accessible to folks. And I think the other end of that is also doing education to our colleagues. There's still a lot of stigma and misunderstanding. I unfortunately still see it in the hospital every day, that people kind of have this misconception about what palliative care is and what we do, and think that we maybe are only for the very end of life, and that's just not the case. So I think we have a lot to do as a profession, as a community, to get the word out about our services and advocate for earlier involvement. Maybe I can open it up to my colleagues for other comments too.
Yeah, so I'm going to answer this a little bit differently and a little bit as an aside. Yes, palliative care early, and as we start to diagnose dementia earlier and earlier, the question is what I don't know how to say this, but what part of palliative care is amazing because frankly, how all of medicine should be practiced is just good medicine. But there's just, the longevity and the trajectory can be very different. So I actually think that in addition to reducing the stigma of palliative care, it's reducing the stigma of a dementia diagnosis. And unfortunately, the reality is that many people are not getting diagnosed with dementia early enough, and they're only getting diagnosed when it's very late or much later when there's already complications and already harms have been done with other medications and overtreatment and et cetera. So there's many things involved here. I can tell you that our colleagues at UCSF are in charge of a massive state-based program called Dementia Care Aware, which is really about training primary care physicians on recognizing and diagnosing and treating dementia. So multifactorial, yes, and more.
Anyone want to add to that? I have a couple easy questions here.
I may add just something real quick to build once again off what Carla was saying, is that there is also this idea about, we sometimes call it primary palliative care. And that's the idea, as Carla said, like this is how medicine should be practiced across the board. And the idea there is that you're the primary care doctor, the neurologist, so they have some of the skills to help think just like we would about what does quality of life mean for this person, to help someone think about what are the future decisions that could be coming down the pipeline in the future. So I do think that's another part of the larger solution.
This is an easy one, and it was, does Kensington have hospice or palliative care? And the answer is yes, we have wonderful partners, but you are free to bring in your own hospice or palliative care community. That was an easy one.
Can I add to that actually? Because
yes,
that's really important. Whether you're at Kensington or other places, many people will tell you that there's a preferred provider, which may be fine. So Kensington may have its preferred partner, but part of the Medicare hospice benefit is that you have a choice of who you choose. And so I've heard, unfortunately, I work for one hospice agency, and my role is to have a person who needs hospice gets the best agency and the best company that fits their needs. It's not always going to be mine. I shouldn't say that to the company, but that is the truth, right? It's finding the right needs for you. And so you can be pressured in many different ways. And so it's just really important to know that you have a choice.
you have a choice and you can interview them.
And you can switch and yes.
This is from Sarah. How do we get hospice care at home for patient with dementia? How about Jeong Min? Do you want to start with that?
Well, I think it's wherever you are, if you're at home, is again looking to see what agencies are around your community. You have the ability to interview them as well and finding the ones that's the best fit for you. Certainly it would be a conversation you have with the doctor as well, and making, getting that order in place and having them help you send the referral over.
I think some really practical things to add to that. So this is coming from the perspective as a hospice medical director, is how do you qualify for hospice if you have dementia? So again, we all follow the same guidelines from Medicare. How they get interpreted vary by company, but kind of a very basic principle for you to think about is that when I think about someone who needs hospice, regardless of diagnosis, I'm looking at the trajectory of illness for the last 6 months. Are they losing weight? Are they eating less? What is their cognitive function like? Which could be even they're sleeping more during the day. The other things that you're seeing with, so it's cognitive, it's nutrition, it's function. They're needing more help with ADL. So big sign in dementia is when you're dependent in more than 3 out of 6 of your activities of daily living. So activities of daily living, bathing, dressing, showering, those sorts of things. So it's not that anyone with dementia can be on hospice. There are criteria for hospice, but that is where what the role of the hospice company is to come in and assess and get a good picture of what someone's like. The really hard thing about dementia and hospice is that trajectories are variable, right? And the Medicare benefit hasn't quite caught up with the reality of dementia. But we have to, as hospice physicians, say in our best estimate, we think this person has less than 6 months. It does not mean they will die in 6 months. It means that we think that it is a great probability. So it's that assessment, and hospice care can be provided in the home. What hospice is available in your community depends on the companies, and it's important to think about things like language and cultural concordance if that's important to you.
You know, I couldn't agree with you more. My dad was put on hospice and off of hospice and on hospice because they felt, I mean, everybody felt that he had less than 6 months to live, and he lived almost 2 years. So I can't remember who said to be an advocate, but you need your team, and you definitely need to be an advocate for your loved one with dementia. And I'm gonna give this one from Sally to Naomi, because this is personal to me, because I really struggled with this, and Chaplain Charlie helped me. But it is, I have such guilt over placing my husband in a memory care facility. I just can't seem to make it go away.
Thank you for that question. And I'm also really sorry. I can hear the loss in those words. It's something that I think, as Susan said, many people share. I think we can be quite hard on ourselves about how we care for our beloved people, that somehow we feel like there is one right way, and that we should be able to do everything, and we should quit work, and we should do whatever it takes. And then what happens is that we burn out. We can't keep going. We can't keep loving the people that we are trying to take care of, and as has been said many times, we don't put the oxygen mask on ourselves first, and then we are unable to show up. The idea that there is some ideal way of caring for people, I think that's gone in this day and age. We are all trying to do our best with the resources and facilities that we have. The truth is that what I hear underneath those words is the deep loss and sorrow that you feel about losing this beloved person, and also having to see them go through what they went through. I think memory care facilities can be excellent supports. They sometimes give us the ability to take away the day-to-day necessities and support for a person, so we can actually accompany them very closely and be with them. So I feel what you're saying, and I also feel that there's also some grief that needs to be touched in. One question I always ask myself is, what does this grief need? What does this grief need in this moment? And then the practical part is, I hear that you and all of us are doing the best we can, and sometimes we absolutely have to look for facilities, resources, and other caregivers to help us out. This takes a village. It really does.
And actually, I'm going to add on to a question that came in. I'm not going to read the whole thing. It's very heartfelt, but there is a gentleman that is working 3 jobs and taking care of his wife, and doesn't really know where to turn, and doesn't really have a village. Any suggestion if you just don't have a village?
So I actually do think, not knowing the details of what advanced dementia stages his wife is at, I actually do think that this is where hospice can provide part of a village. It's not everything, but again, this is where knowing which company and which group to work with can be critical. I mean, I have patients on hospice with me that during difficult transitions, we are seeing them every day because that's what's needed. And we, and it's everything from the home health aide to help if you're at work and she needs to take a shower. It's our nursing visit. It's myself as the physician. It's our volunteers. It's our chaplain. It's our massage therapist that helps with, anxiety or anything that's contributing to behaviors. Like, that is part of the village. It is not an entire village, but it is part of it. I think the hard part and the hard reality of care in this country is that a lot of it still falls to family, but this is where also the social worker on the team can help to figure out, have we maximized all your benefits through your insurer? Do we need to look at respite for you so we can give you 5 days that Medicare will cover so that you can do what you need to do and we'll help your wife? Do we start looking at long-term care? And so there is room within hospice. I also think there's amazing, and I'm sure you're going to share, Susan, resources, Family Caregivers Alliance, et cetera, to really think about how do we build a village. And then there is, of course, a San Francisco Village and other villages in here, which are a network for people who are aging.
I just want to add to what Carla said. We make up for systems that don't work because we care and we love people. our healthcare system is broken. It's not complete. There's no guarantee that our loved ones will get the care that they need. At the same time, we cannot on our own backs make up for the system that doesn't work. So we want to get the best resources and reach out to get the best help. At the same time, our natural tendency is to blame ourselves when we're feeling tired, to blame ourselves when the systems fail us. But I think we really have to name it, that we have very imperfect systems to take care of our loved ones when they're going through this, and to support ourselves. And there is legislation and a movement out there for caregivers now in a way that I've never seen it. And we are thinking about caregivers as actually, you know, these precious resources that we need to support. So I just want to say that there's light coming through on this too.
And please take care of yourself, because if you don't take care of yourself, you can't help your wife. Dr. Smith, I'm going to start with you on this from Todd. What should I expect when starting hospice for my wife?
Yeah, I'll also invite Carla too as our resident hospice provider here. But from my lens, what I see is, you know, the hospice will meet the individual where they are, provide an overview of the services that they provide. I personally feel that like the biggest benefit of hospice is sort of what Carla was saying, is that there's this ability to dial up or down the services depending on what the individual needs. And that includes having, as Carla said, like having a nurse come to the home every day if that's what's needed to get a difficult symptom under control. And if things are going okay, everyone's status quo, you know, they can sort of dial that service back down. But I think that it's so individualized that it's kind of can be a difficult question to answer, but that's a good thing. Like we want something that can be individualized and tailored to the person. So that's sort of my initial thought, and I'll see if Carla has other thoughts there too.
Yeah, so I think that's a good way. I think the other thing is, much like when you're meeting any other healthcare provider, team, or village, we're getting to know you. We're getting to know you and your family member, right? There's a lot of annoying logistical things that have to happen up front, which is signing of papers and explaining. And for some, it can be overwhelming at first, like, oh my goodness, this is a lot. For other people, it's like, thank goodness someone is here to help me. And then as we get to know your loved one, we figure out what the right cadence of visits is. Something that's also really important to know is, you're right, is that just because someone's on hospice doesn't mean they need to be DNR or DNI. Just because someone's on hospice doesn't need to mean they have to have all these medicines in the home. There's many times that, depending on the person, I go meet them and I say, okay, let's talk about what your goals are. What do you want? Do we want to have something here for emergencies so that we have something as a medication? What are your preferences on medication so we know what not to do? I think, again, this is where it goes back to what I said earlier, is you have to advocate. I have unfortunately had families that have been pressured into feeling like they had to give their loved one a medication. That is not true. You are in control. We are the ones that help you achieve the goal that you need for your family member. The other last thing, sorry, but I have to say this, is that there's so many hospice agencies in our area right now, so much so that they stopped the growth of them. So just be very thoughtful and ask questions, because the Medicare guidelines about what every hospice has to provide is very clear, but not everyone provides them. So just be thoughtful in terms of asking questions.
And I'm going to ask this question. It's 3 questions, but I'm going to combine it. So be patient with me. But is it hard getting palliative care? How do I get outpatient palliative care? What are the criteria for getting palliative care? And is it covered by Medicare? Dr. Smith, you want to start with that?
I'll start and do my best. I'll try not to lose track of the questions. So
it's in the Q&A. You can see
okay.
it.
Well, first, like sort of all healthcare, you know, unfortunately, there's a lot of geographic variability. So, you know, we practice in the Bay Area here in California, and we're really lucky that there are a lot of high quality palliative care teams up and down the Bay Area. And so the availability and access to palliative care in the Bay Area is very good. You know, in more rural places, some of the studies out there about where palliative care is sort of not as robust in areas like the Southeast. So a little bit of that has to do with geography. How to get connected to palliative care? One is that there is a great national resource through our website, and we can send this out in our resources, but it's getpalliativecare.org. And you actually can put your zip code in and search for like a hospital-based, home-based, or outpatient clinic program. And that's really sort of like the national clearinghouse, I would say, for palliative care programs. So if someone asks me, how do I find it? I say, that's the place to start. Another place to start is to go to like your insurance portal. So I know when I was preparing for some of these talks, I actually went into my Aetna and said, I want to find palliative care. And that is another way to find providers that your insurance company contracts with. So that's another way to sort of find palliative care. Talking with your healthcare providers, I think, is another great resource. Often your providers will be keyed into what the local resources are. So I think that's always a good step. It also is very helpful to have a referral to a palliative care team. That's typically how a lot of sort of specialist care happens. So having that referral to a palliative care team often helps it get cleared by the insurance and get it covered and get you to the right folks. In terms of coverage for palliative care, I'm going to speak very, very generally, and I know Carla has some experience in this too, and Jeong Min, you may as well. But in general, palliative care for private insurers is covered like other services. So like if you go to see a heart doctor, a cardiologist, if you pay a copay, you pay your copay, and insurance sort of covers the rest of the bill. And that can happen with palliative care too, that you pay a copay, but your insurance covers it. Here in California, there's been some legislation passed to improve access to palliative care for public health insurance, like Medicaid or Medi-Cal is called in California. And that can be a little bit variable, but it can be hard to answer that question very generally because it can depend a bit on the specific insurance coverage, but there has been increasing coverage of palliative care services. Carla, do you have other thoughts or ways you sort of answer that general question about the coverage and accessing?
No, I think that's right. I think you give great resources. And the other thing is that sometimes we find you. So, but I think I'm going to go back to the advocacy. Is there are times that you may realize that you need it or your family member needs it before someone else does. I just took care of someone this weekend. I went in to talk to her about hospice. Turns out that she had already called hospice 2 days before, yet nowhere in the medical record had anyone talked to her about palliative care and hospice. So this means that she knew her family member was declining. The healthcare team was so bogged down in the little details that didn't see the overall person, as Naomi has so carefully talked about. So there are more resources now. There's still a dearth of palliative care and geriatricians. I'm going to throw myself in there, but there are good resources. You did a great job, Grant.
I will say, just to add to Carla, that I would also agree that advocating for yourself is important. As we just had talked about earlier in the Q&A, some of our colleagues are still learning about our services. And so when I talk about palliative care, I tell people, it's okay to be a little bit insistent that you think this is a benefit and something that you want to explore. Use this talk as an excuse, like, hey, you just sat with 2 doctors, a chaplain, and a social worker who are experts in the field. And, you can try to use this too, say, hey, I just wonder, would this be helpful for me as a conversation starter with your providers if you feel it would be helpful?
To our audience, thank you so much. Good evening on the East. Good afternoon on the West. And I can't thank you enough, everyone, to our presenters today. And I'm going to reiterate again that you will receive a copy of this. I suggest you share it with friends and family. The more we can get the word out there, the more we can encourage people to advocate for themselves, the better off we're all going to be as a community. And I'm going to end with one thing, and that is feelings don't get Alzheimer's. Thank you so much and have a nice evening.